Hi, I'm Paul Glasziou. I'm a GP researcher at Bond University and interested in the better use of research, and today I want to talk to you about how we grade recommendations in guidelines. Okay, so guidelines may make recommendations for treatment, but the uncertainty about their value can vary. Some can be strong recommendations, some may be weak recommendations. It's a bit like the weather report here, that there's a probability with the chance of showers. We have the same problems with the recommendations that we make in guidelines, that there's a degree of uncertainty. So there have been many systems developed for this. You may have heard about the NHMRC's levels of evidence, but they've all been unclear, and so several years ago a group got together to form an international collaboration between NHMRC, SIGN, the US Preventive Services Task Force, WHO, NICE in the UK, etc., who've developed an international standard agreement called the GRADE collaboration. GRADE's a recommendation of assessment, development and evaluation for grading the uncertainty of recommendations in guidelines. And one of the co-founders of that was Andy Oxman, a GP in Oslo. So what is GRADE? There are two components of grading. The first is to look at the quality of the evidence. That is, the certainty that the estimates of effect have adequate support for decisions. And this is the quality of the body of evidence coming usually from a systematic review. The second component is how strong is the recommendation. And this is because there may be positives and negatives, or it may be about the uncertainty of the evidence. So we can have strong or weak or conditional recommendations, and those can be for or against. That's done for many guidelines now, so let's just look at one quick example to see what it looks like. There's two here about the preventing fractures in long-term care. The one for calcium and vitamin D is a strong recommendation, but it's based on moderate quality evidence. Okay, so a bit like the weather report giving you the 70% chance of rain, in brackets after the recommendation is a statement about those two elements, the strength of recommendation and the quality of evidence. And if we look at the exercise one, we can see that we have the same quality of evidence, moderate quality evidence, but a conditional recommendation. Now the words conditional and weak are both used, they're alternatives. I actually prefer the term conditional, as many GPs do, because it indicates that the recommendation is sometimes useful for some patients but not in all circumstances and not suiting all patients' preferences, so that we need to individualize the decision. So I'm not going to go into the details of how we get the quality of evidence, but just to give you a rough idea of how it works, the quality of evidence process is in 3 steps. We first of all start with a ranking of a systematic review of randomized controlled trials for treatment. We'll call that high quality evidence to start with, whereas if we've got observational studies, we'll start by assuming that that's low quality evidence. But then we need to look at a number of details for which we can downgrade or upgrade the evidence. For example, are there significant risks of bias? Is the evidence across studies inconsistent? Is this indirect evidence in terms of the outcomes that have been used? Is it imprecise if there were small sample sizes in all of the studies, for example? And do we have a risk of publication bias? That is, that some of the reports have never been published and they would have a more negative result. We can also upgrade for a few things though. A large and consistent effect, if there's a steady dose-response relationship, as we increase the dose, we increase the effect. And finally, if all the potential confounders, the things that could distort the result, could only reduce the size of the effect. And then from those we assign a grade of high, moderate, low or very low. starting with randomized trials at high. If we'd downgraded 2 steps, for example, we could end up being low. But we could have started with observational studies that had stepped up twice and had nothing to downgrade and end up being high. Okay, once we've done the quality of evidence for all of the outcomes that we're interested in, then we need to look at the strength of the recommendation, as we saw with the prevention of fractures. So the quality of evidence certainly comes into here, but we also need to consider the balance of desirable and undesirable effects. We need to consider the cost effectiveness of this. Is this feasible and reasonable within our practice setting? And importantly, we need to consider patient preferences about the trade-offs. For example, between preventing vascular events and having bleeding on the other hand. And those preferences may be different to the clinician's preferences, which is important to note. From taking all of those things into consideration, we can have a recommendation that is strong for, could be weak for, it could be strong against, or it could be weak against. And again, we could use the term conditional rather than weak. Now remember that there are lots of different ways that we may end up seeing these grade recommendations. It's not always in the textual form that I showed you in the first example. Here's one from the BMJ Rapid Recommendations. There's been a sequence of these coming out in the British Medical Journal recently. And here they use the grade system, so you can see in the recommendation here that they favour conservative management. So this is a strong recommendation against arthroscopic surgery. Now why is that? If you look down below here, we can see some of the evidence. There's moderate to high quality evidence, but it all suggests that there's no important differences in pain or function long term. There's a small short-term benefit, and if we looked below this, I haven't got the whole thing here, we would also see that there were some downsides, some risks, for example, of getting blood clots and anesthetic complications or infectious complications. And so, on balance, they've decided that this should be a strong recommendation against. Okay, so that's the basics of the grade system, that it rates the quality of evidence, and it also then uses that to rate the strength of the recommendations that you will see hopefully in the guidelines that you read. So good luck with reading your guidelines.